Assalamu alaikum. In this presentation, we will discuss blood flow restriction training, or BFR, from a clinical physiotherapy perspective. The goal is to understand what BFR is, why it works, and what the evidence says, and most importantly, how we can apply it safely and effectively in rehabilitation practice. This is especially useful when patients cannot tolerate heavy resistance training but still need to improve strength and muscle function. So, what is the PFR training? Blood flow restriction training is a rehabilitation and exercise method where a cuff is applied around the upper part of a limb to partially or fully restricted blood flow during low load exercise. So the key concept is fully or partial venous occlusion while maintaining some arterial inflow. Okay, so in simple terms, blood can still enter the limb, but it leaves more slowly. This creates a unique physiological environment that allows low load exercise to produce adaptations that are usually associated with heavier training. Let's talking about the history and the origin of PFR. The origin of PFR training go back to Japan in the 1960s when Yoshiki Sato began developing what was later known as Katsu training. Over time, the concept evolved from experimental use into research-based application. Interest then expanded through military performance settings, sports science, and eventually rehabilitation. So today, PFR has become an important evidence-informed tool in both athletic and clinical populations. How does it works? The effectiveness of PFR is mainly explained by several physiological mechanisms. First, it increases metabolic stress, meaning byproducts such as lactate accumulate more quickly. And second, it causes cell swelling, which may contribute to anabolic signaling. Third, it increases motor unit recruitment, especially of fast twitch fibers, even though the exercise load is light. And finally, it stimulates a hormonal and molecular environment that supports muscle adaptation. So all of these together uh, help explain why patients can gain strength and muscle size without lifting heavy loads. So why does it work, especially at low loads? Normally, to build muscle effectively, we think of using moderate to high loads, often around 70 to 85% of one repetition maximum. But with blood flow restriction, similar adaptation can be achieved using much lighter loads, usually around 20 to 40% of one repetition maximum. So, what is the importance of these words clinically? Clinically, this is extremely valuable because many patients after surgery, during pain, or in frail conditions cannot tolerate heavy resistance. PFR gives us a way to create a stronger training stimulus while keeping mechanical stress relatively low. So, what about the evidence about the PFR? The research on PFR has gone significantly over the past 2 decades. Across multiple studies, PFR has shown positive effects on muscle hypertrophy and strength. especially when compared with low load exercise alone. So, some research also suggests potential benefits for function and even bone related outcomes, although that area is still developing. What is important for clinicians is that the evidence consistently supports BFR as a useful option when traditional heavy loading is not appropriate. So the best supported and based evidence outcomes are muscle size and strength. What are indications and who is it for the PFR? So PFR can useful for several patients groups and populations. One major group is post-surgical patients, such as those after ACL reconstruction or joint procedures, where heavy loading may not be possible early on. Okay, so it's also relevant for older adults with sarcopenia because it allows meaningful training at low intensity. Athletes also may use it during deloading or returning to sport phases or in season phases. Okay? In addition to that, some chronic pain populations may benefit because PFR can help improve strength while limiting joint stresses. There is also growing interest in its use in oncology and other medically complex populations with appropriate screening. So, clinical reasoning still comes first. PFR is a tool, not a diagnose specific treatment by itself. Contraindications and precautions. Like any clinical intervention, PFR is not suitable for everyone. We need to screen carefully before using it. Important contraindications and precautions may include a history of DVT, severe vascular compromise, uncontrolled hypertension, and open wounds. Okay? And finally, pregnancy in some contexts or other significant medical concerns. The key message is that PFR is not simply about applying a cuff and exercising. It requires clinical reasoning, patient screening, and individualized decision making. And what about equipment or devices? The type of equipment matters. Okay, in practice, pneumatic cuffs with the ability to measure or estimate limb occlusion pressure are preferred because they allow more accurate and individualized application. Elastic bands and improvised methods are less reliable and may increase the risk of underdosing or overdosing the stimulus. Another important concept is limb occlusion pressure or LOP, which helps us decide how much pressure to use safely. So, in modern clinical practice, PFR should ideally be performed with certified devices rather than improvised system. Okay? How to apply PFR step by step. A practical PFR session usually follows a simple structure. First, place the cuff at the most proximal part of the arm or thigh. Second, determine the appropriate pressure, ideally based on the patient's individual limb occlusion pressure. Third, select a low load exercise. A low load exercise often between 20 and 40% of one repetition maximum, or sometimes body weight in early rehab. A common repetition scheme is 30 repetitions in the first set, followed by 3 sets of 15 repetitions with um, with short rest intervals. Let's say 1 minute. Okay, so this approach creates a strong training effect while keeping the external load low. So the typical structures of the sets and reps: 30, 15, 15, 15. Pressure and safety. Okay, what is LOP? Limb occlusion pressure refers to the minimum pressure required to stop arterial blood flow into the limb. Okay, so in practice, we do not train at full occlusion, and instead of that, we use a percentage of that value, commonly within the range of 40 to 80%, depending on the limb, patient, and the treatment goal. This is important because pressure should never be one size fits all. Factors like limb size, cuff width, tissue composition, and blood pressure can all influence the required pressure. Individualizing pressure is one of the most important safety principles in PFR. So let's talk about the BFR in post-surgical rehab. In post-surgical rehabilitation, PFR can especially valuable when muscle atrophy and weakness develop quickly. Okay? But high load strengthening is not yet allowed. This is the important point. For example, after ACL construction, PFR can help maintain or improve quadriceps strength during early to mid rehabilitation. Similar principles may apply after joint replacement or rotator cuff repair, depending on the surgical protocols and tissue healing. The clinical advantage is that PFR helps bridge the gap between protection and progression. So, PFR in the elderly population. In older adults, one of the main challenges is how to improve strength and muscle mass without exposing the patient to excessive joint stress or heavy mechanical demand. This is where PFR becomes very attractive. Low load exercise combined with blood flow restriction can produce meaningful muscular adaptation in people who may not tolerate traditional heavy resistance training. For sarcopenia and age related weakness, this may offer a practical and clinically relevant strategy to support function, mobility, and independence. So let's talking about the blood flow restriction with aerobic exercise. PFR is not limited to resistance training. It can also be used with low intensity aerobic exercise such as walking or treadmill training. This is particularly interesting for deconditioned patients or those who are not ready for more demanding resistance programs. Some studies suggest that aerobic exercise combined with PFR may improve muscle function and even aerobic capacity more than the same light exercise without restriction. So PFR gives us another option when designing progressive rehabilitation programs. And what about the side effects? When PFR is applied correctly, it is generally well tolerated, okay? But patients should still be educated on what they may feel. Common responses include pressure discomfort, burning sensation, and muscle soreness afterward. Okay, And finally, temporary skin marking or mild headache. Okay, so these are usually expected and manageable. Serious adverse events appear to be rare when proper screening, correct pressures, and appropriate monitoring are used. So finally, the good communication and observation during the session are very essential. Okay, so what is strong evidence and what is emerging evidence? When we look at the current literature, the strongest evidence supports that PFR for improving muscle hypertrophy and strength, especially when heavy loading is not possible. Promising evidence exists for post surgical rehabilitation, older adults, and some functional outcomes. Other areas, such as long term outcomes in certain special populations or effects on bone and broader performance variables, are still emerging. So, as a clinician, uh, we should be confident in in the established uses, but also realistic about where the science is still developing. So you can use very, very, very strong in muscle hypertrophy or the muscle strength. Okay, so let's talking about practical tips for the clinic. In the clinic, success with PFR depends not only on the protocol but also on how we introduce it to the patient. Um, you have to explain the purpose clearly and describe what they are likely to feel and reassure them that low load exercise can still be effective. So start conservatively, especially during the first session, and monitor symptoms carefully. Document cuff location, pressure, exercise used, and patient response, and any adverse signs. So this is the most important thing that you have to in the first session. And good BFR practice is structured, individualized, and well monitored. Okay, so there are key takeaways. If I have to summarize this presentation into a few key points, they would be: first, PFR allows meaningful training adaptations with low load external loads. Okay. Second, it is especially useful in rehabilitation when heavy loading is limited. And third, individualized pressure selection is essential for safety and effectiveness. Fourth, the evidence is strongest for muscle strength and hypertrophy. And finally, PFR is not just a trend, it is a clinical tool that works best when applied thoughtfully and professionally. Okay? Finally, you can find the references that I use for this presentation. You can ask me these references and I will give you by direct messages. Thank you.